This patient has a dislocated lens 6 years after surgery. After performing an anterior vitrectomy, I mobilize the IOL above the iris and then repeat viscoelastic administration above and below. Next, I'm going to create my main wound so I can cut the lens in half, and in a bimanual fashion, I cut it about 90% across. This will allow me to cartwheel the entire IOL through the main incision. And here comes the second part of the IOL, and then here comes the capsular bag. I'm going to repeat anterior vitrectomy. It's very important that you do this before proceeding with the remaining steps of the Yamane technique. I do like to place dispersive viscoelastic over the cornea, and now I'm going to measure halfway across the corneal diameter and then 2.5 millimeters from the limbus on opposite sides, and then 2 millimeters across. And then I'm going to perform my subtenon block here. I do like to perform the block after marking. This prevents the marks from getting displayed here. Now, with the bimanual approach here, I'm going to use my left hand to pass a 30 gauge TSK needle. My right hand feeds the haptic into the lumen of the 30 gauge TSK needle. Now I drop the needle and then switch hands. My right hand is holding the 30 gauge TSK needle. My left hand will feed the haptic. The trailing haptic is always a little bit more tricky, but it goes in after the second attempt. Now I'm going to externalize both needles to basically pull out both haptics. And now I'm just going to adjust the haptics to ensure appropriate centration. Now I'm going to apply low temp cautery to create two small terminal flanges. They should be very, very small, and it's very important that you tuck them into the intrascleral tunnel as I'm showing you here. And you can see the IOL is well centered. I'm going to repeat anterior vitrectomy to check for any vitreous and to get rid of any viscoelastic. I administer Myocol and intracameral moxifloxacin and hydrate all my incisions. I hope you found this case to be useful, and thanks for watching.